there's a conversation in dentistry about the difference between grammetry and photogrammetry. You want to talk about that?
Yeah, I'll talk about it a little bit. So it's kind of a hot topic. Some doctors will debate for hours on end that, what we have isn't true photogrammetry, but I'll tell you it is. And Dr. Isaac Tao will debate any person on it for hours on end. But what grammetry is it's just taking the geometry of a shape and using that geometry to determine the positions of those implants. What photogrammetry is, it takes not only the geometry, but a shape and correlates the shape to a measurement. And that's the difference. So photogrammetry uses a shape plus a measurement and geometry, whereas grammetry is just purely using geometry. And so there's a significant difference in the accuracy levels that are achievable from photogrammetry to grammetry. And it's anywhere from 70 to 120 microns of discrepancy that we're talking about, which, doesn't seem like a lot, but when you think about it, I was explaining this one time, the average strand of hair thickness is 70 microns. So, that's the level of accuracy we're talking about. 70 microns is the thickness of a hair. And so they say for implant dentistry, the goal is to be under 150 microns of accuracy. If you're under 150, you should be good to go.
Yep.
Grammetry wavers right around 100. I think some of the best can get down to like 70 or 80, but all the way up to about 150 microns. Okay. So you're, kind of borderline, you're running some risk. Whereas with photogrammetry, you're looking at down to 18 microns to around like 45 for some of the best systems that are out there. So you're looking at twice as accurate between photogrammetry and grammetry.
Okay. How do you think that argument came up? Why would one company say, well, we're photogrammetry and they're not?
Just because they have a stake in the industry and they don't want to see another company succeed. And so a lot of people will say, oh, well, your photogrammetry isn't real because you're taking, more than one image. And it's once you start combining images, you create what's called stitching. And as a scanner is acquiring data, it stitches all these individual images together to create the STL file or the scan of itself in its entirety. And if you're stitching, well, then it's not true photogrammetry. Well, it's also not entirely true because a photogrammetry machine like the iCam or Micromapper, they still have to combine an intraoral scan to the picture that it's taking. So it's still stitching. So in that case, what they're saying isn't real photogrammetry then either. And some people will debate for hours on end, and it's really neither here nor there. What it really comes down to is it's taking a shape and correlating the shape to a measurement. And that's that. Our technology, they've coined a term, is video stream based photogrammetry. So our photogrammetry is taking a video, it's collecting all those data points of those dots and doing all the measurements, and that's what the photogrammetry is.
Okay, so with PIC, for example, the photogrammetry scan is like from a ways away. It's like from like 3 feet away, right?
Yeah, and it's one shot. It's just one image that's getting taken from, I don't know, 2 or 3 of the cameras. And that's where it's doing all the calculations.
Right. And so what I think I hear you saying is that is going to be unnecessary, and 3D Shiny is not interested in working on anything like that. Instead, they feel like, hey, what our system is already reaching the acceptable levels of accuracy, right?
Yeah. Oh, more than, yeah. We've got the studies to prove it.
Good.
And I don't really know that saying it's unnecessary is really the right way to put it. It's just a different way of doing it. And, I'm not knocking them at all. Like the PIC is proven to be the most accurate. It's down to an 18 micron level of accuracy, whereas ours was sitting at 27 microns. So with a tolerance of 5. So, we're talking about 9 microns of a difference. So barely anything at all. What it really comes down to is the workflow that it provides. And the fact that it's an all-in-one solution. You don't have to have a $40,000 photogrammetry unit alongside your $30,000 Trio scanner alongside your, $30,000 or $40,000 other printer setup. So you're looking at almost $100,000, depending on what solution you're looking at for photogrammetry. Whereas ours, it's $20,000, $21,000 for
everything.
Our intraoral scanner and photogrammetry, and you get everything you need to get the ball rolling. So it's significantly less expensive, and the workflow is actually faster for what it allows to be done. We're the only one that the alignment of the soft tissue to the scan flags happens within our software, as well as the scan flags converting to virtual scan bodies of whichever implant system the doctor likes to use. So with that all being done inside of our software, that's why the labs love it so much, because they can do their design so much quicker because they don't have to spend 30 to 45 minutes of tedious aligning these data points together in exocad, whereas ours does it for them. Sure, some labs might be able to do it faster, maybe say 10 minutes or 20 minutes, but especially if you're combining with a face scanner as well, being, again, the fact that the alignment happens within our software of the intraoral scans to the face scans, it's a huge benefit to a lab, because I was at a lab down in Utah. They were scanning with their clinic was using the Instarisa, and they told me they spend 45 minutes aligning the intraoral scans to the face scans. And I'm like, really? Because ours does it in 10 seconds. So, I mean, it's a huge difference, and the quality is there.
Yeah, that's great. And is it the facial scanner that you guys have? Which one's newer, the intraoral scanner or the facial scanner?
The MediSmile launched in 2022, I believe.
Okay. So the intraoral scanner's the latest, right?
Or early 23. It was not too long. It was introduced, I think. That's a great question. I don't actually know the exact release date of the MediSmile, but I'll say overall the MediSmile is newer in general to the market, just because not as many offices have a face scanner.
Right.
Our intraoral scanner came out in 2017. The Elite came out September of 24, and the wireless version of the Elite came out in May of this year. But yeah, just generally speaking, intraoral scanners are a lot more. They're used a lot more in the industry right now than the face scanner, but those offices that are using the face scanner are benefiting so much. It's really my favorite thing we offer, purely from the patient experience standpoint and the patient communication standpoint, case presentations. And that's just the one side. The other side that's even cooler is what the lab gets. It's a lab's dream to have the amount of data the face scanner provides. They're not just using the papilla and guessing where the midline is based off the papilla. They can see all the proportions. I have a slight cant in my smile.
Right.
And so the MediSmile would really benefit someone like me because of the cant I have in my mouth. It's going to make sure that everything is going to look nice and pretty the way I'm used to it.
Well, you're beautiful just the way you are, man. And I'm sure the ladies feel the same way. But the thing that people don't understand is that what a dental lab sees is basically just an arch of teeth without the face.
Right.
And so they're really guessing on on a three-dimensional object that has to look good in the face. So the fact that the facial scanner exists at all gives the dental offices that have one a big advantage. And we've really enjoyed using both Instarisa and the MediSmile. The sharpness of the MediSmile is something that my labs are saying, like, okay, so the Instarisa has better clarity, and I can show you a side by side there. But the ease of scanning is night and day with that. Like, my assistants are literally just having my patients just like face, and they're done. And so I want,
I'd be curious. Yeah, I'd be curious to see that. We can try to dial it in because it really is kind of dependent on lighting. So if we can get some kind of setup with these light boxes or something, it can really, really help the sharpness and clarity of those scans. Because I was in an office here in Utah, and they had the Instarisa, and the scans I saw, it was like no comparison. There were the scatter on the teeth, and it wasn't capturing things nearly as crisp as ours was. But
what's the best practice then? Like, what is it? Lights off in the room, or a spotlight, or what?
Yeah. So what I've found to be best is ambient lighting. Sometimes I'll turn off the lights actually in a room with just a little bit of natural lighting coming into the room. That's usually what I find to be best. Like I went into Dr. Marta's office and they were testing out the MediSmile. They had a big light box similar to what these light boxes are in here. And she had all the lights off and just the natural lighting coming in. And so I think an environment like that is best. And you can kind of tweak around with it and see, but I definitely think, you know, I'm not going to say every time you take a scan, it's going to be perfect. Like you might have to rescan once or 2 or 3 times to make sure that it's as perfect as you need it to be.
Okay.
I'll say more often than not, I'm happy with the first result I get.
Yeah.
But, you know,
with Instarisa, we're supposed to turn the lights off in the room. So we're always doing that. But with MediSmile, not doing that. We're also scanning in a different room. With the MediSmile has like 2 windows. No, none of the lights get turned off, nothing like that. There's no consideration for lighting. So we'll start doing that.
Yeah, it can make a huge difference.
Yeah.
Yeah.
Well, we can easily bring in, a light for extra lighting if that's what we need. But is it optical, laser, or both?
It's an infrared camera that it's using. So it's projectors as well as 2 cameras. So there's a 1.2 megapixel camera as well as a 5.0 megapixel texture camera.
Okay, so I wonder if we should be turning off the overhead lights.
I would. Okay. Yeah. All right. I mean, you play around with it and we can even do some testing and dial that in, but definitely lighting in the room can make all the difference in the world. Because sometimes I take a scan, I'm like, that's more distortion than I'm used to. Like we were at a trade show and we have these, banners behind us and there's these lights that stick over the banners and the lights were shined like right onto the face, and so it really caused like way too much brightness in the teeth and it wasn't capturing. But I turn those lights down and then boom, I'm getting nice sharp crisp scans and I'm like, yeah, beautiful. So
all right,
lighting makes all the difference in the world.
All right, sounds good.
Even in intraoral scanning, you never want to have an overhead light when you're intraoral scanning, just because the structured white light that comes from the scanner itself is all the lighting it needs. If you have extra light, it can cause color distortion too. And that's not just our scanner, that's across the board.
That's great. Yeah. We're going to start doing that. And that's great. And I know what you mean. If you have too much light, like for example, like isolite, like where the whole, there's backlight.
Yeah.
You can just kind of wash out any shadows and you lose a little bit of depth perception there.